it's Caitlin from C-SPAN. Did you know that C-SPAN has been serving the American people for 45 years? Since our founding in 1979, C-SPAN has been documenting history with a unique approach, unfiltered, without commentary, and entirely independent from government funding. C-SPAN is funded by fees from our cable and satellite distribution partners. And now, with fewer people subscribing to cable and satellite, we're asking you to help support our next 45. Your contribution helps to ensure that we can continue to provide unfiltered, complete coverage of government proceedings on TV, online, on radio, and our mobile app, as well as context through newsletters, social media, and podcasts. Join us in preserving this legacy of access to the democratic process. Make your tax-deductible donation today at cspan.org/donate. Thank you.
Dr. Uché Blackstock, the name of your book is Legacy, A Black Physician Reckons with Racism in Medicine. You happen to be a legacy at Harvard. What's that story?
Well, first of all, thank you so much for having me on. What that story is that my twin sister and I, along with my mother, we are the first Black mother-daughter legacy graduates from Harvard Medical School. My sister and I graduated in 2005, my mother in 1976. So in essence, we made history.
You write about your mother that she wasn't exceptional, but she was just one of the lucky ones who made it through. What do you mean?
Yeah, and I think it's so very important. When I talk about that legacy, there actually are, since I graduated in 2005, there's only been one other Black mother-daughter legacy graduate from Harvard Medical School. So we're still talking about first and seconds, in the 2000s. And so all that to say is that, my mother, she grew up in a very, very different circumstances than I did. She grew up essentially in poverty, on public assistance, had a very challenging childhood, but was, lucky enough to have mentoring along the way. She was the first person in her family who went to college. And in college, she had a chemistry professor who encouraged her to apply to medical school. He was a Black man, saw her potential and encouraged her. But I say that, she wasn't exceptional. I mean, obviously she was a brilliant woman, and deserved everything, all the accolades that she received. But at the same time, there probably were so many other young children from her neighborhood who also could have ended up at Harvard Medical School if it weren't for poverty and systemic racism, because what that does is it decreases access to opportunities, access to resources. So it's so important when I tell my story and my mother's story that we also talk about the many other people that could have been there, or have been physicians or other health professionals today, but are not because of the legacy of racism.
And her name was Dr. Dale Gloria Blackstock. What kind of medicine did she practice?
Yes, I refer to her as the original Dr. Blackstock. She was actually triple boarded, of course, internal medicine, nephrology, which is the study of the kidneys, and geriatrics, which is, a specialty within medicine. We care for elderly people. So she was triple boarded. And she actually, after Harvard Medical School, she came back to New York City and trained at Harlem Hospital, and then worked in the very same neighborhood that she grew up in central Brooklyn, essentially taking care of her family, friends, and neighbors.
You say that she chose nephrology for a reason. What was that?
Yeah, I think she chose nephrology. Well, one, because it probably is one of the most challenging specialties. The kidney is such a sophisticated organ. And so I think that's one reason. But the other reason is because within Black communities, there is a very, very high burden of chronic kidney disease. And that is a result of ultimately of systemic racism. Diabetes, high blood pressure essentially leads to kidney disease. And what we see as lack of access to healthcare, lack of access to healthy foods, lack of access to culturally responsive care, and other determinants actually are the reason why we see a higher burden of kidney disease within our community. And my mother ended up working at a hospital in a neighborhood that probably has some of the highest kidney disease rates in the country.
Now, you write in Legacy, quote, I believe our mother practiced what is now known as structurally competent and culturally responsive care, which means that the entire complex nature of the patient's background and the social context in which they live, work, love, and pray is considered during evaluation. Why are those things important when it comes to medical care?
Sure, they're important because I will say this, often, the medical model or the biomedical model of how we're taught in our medical training and education is that, individuals are the most responsible for their health. Like the individual choices that someone makes is what makes them healthy or not. So, that's why we talk a lot about what you eat and, not drinking alcohol and exercising, but actually what really makes someone healthy, it's probably about 70 to 80% they have no control over. That is related to systemic factors like the neighborhoods that they live in, the workplaces that they spend a lot of time in. That actually is what determines how healthy they are. And so when I think about the kind of care that my mother practiced and delivered to her patients, she really was recognizing that when she was in the room with her patients, it wasn't just her and her patient. It was their patients, their family members, their fellow colleagues, employees, the kind of workplace that they live in, really taking into consideration all of the factors that we know today that determines how healthy someone is. And very much so, that is, it's less dependent on the choices people make and more so determined on their environment, which is a model that, I think not enough medical schools and residency programs focus on, but that we know from the data has the largest impact on how healthy people and communities are.
Dr. Blackstock, you mentioned a couple of your mother's mentors, and I want to call them out by name. Doctors June Mulvaney and Dr. Mildred Clark. Who were they?
Yes. Well, Dr. June Mulvaney was my pediatrician, a Black woman. And, I talk in the book about how growing up, my mother would take us to, she was often in leadership positions within either Black women physician organization or local Black physician organizations. And she would take my sister, Oni, and me to these meetings. So I really was exposed to what it means to be a Black physician at a very, very, very early age. And even my pediatrician, Dr. June Mulvaney, who was someone very well known and respected in our community, was someone, who'd been caring for me and my sister since we were babies, essentially. Mildred Clark is a physician, OBGYN, who lived on our block, in Crown Heights, the only neighborhood that we lived in before we went off to college. And so I really had this, what I didn't realize was a very rare experience and exposure of being surrounded by Black women physicians growing up, to the point where I thought that most physicians were Black and Black women, until I got to college and recognized that most of the pre-med students did not look like me. And so these women, though, were obviously role models to me, just like my mother. And that representation was so important in helping me give me the confidence to recognize that being a physician was something that was possible.
You describe your mother at Harvard as a fish out of water.
Yes. I talk about how when she got to Harvard, that she was, some of her classmates had parents who had written the textbooks that they were using. There's another classmate who was a relative of Jackie Onassis. There was another classmate whose parent had won a Nobel Prize in immunology. And, at that point, my mother, what she could say is that her own mother had worked full time, gone to school full time, managed to get off of public assistance, became a licensed practical nurse. And she was very proud of her mother in that respect. But it really was kind of a culture shock for her to be at Harvard Medical School, surrounded by people who had tremendous amount of resources, opportunities, who had family members who were physicians, where she was like, the first to go to college, first to go to medical school, but she was fortunate enough to find her group of friends there. And I have to say that when my mother started medical school, she started around the same time as many of the diversity initiatives started. So her class at Harvard Medical School was about 10% Black, and that really was in the wake of MLK Jr.'s assassination that some higher education institutions had implemented these diversity initiatives.
One of the details you put in about your mother was that she had a scar on her forehead, a rat bite scar.
Yes, it's interesting because I think now as an adult and holding all the multiple roles that I hold, I think now I'm able to see my mother and all the fullness that she was, in addition to being a mother, but reflecting as I was writing the book on some of the experiences she had. The fact is that my mother, lived in poverty, and that scar on her forehead was from a rat bite. So that those were the kind of conditions that my mother was living in that I could not even imagine, because she and our father were able to give us, just more security and safe housing than she had growing up. So now when I reflect on all that she had gone through to then end up at Harvard Medical School, as an adult now reflecting on that, I really see the challenges that she had to encounter. To come from that, to come from a setting where you are living in a rat infested apartment to graduating from Harvard Medical School is something that not many people can say.
What did she mean when she would say, "I have to get my bearings together"?
Oh, yes. That was one of my mother's favorite phrases. And so, I think, like I say, like I didn't recognize, obviously, as a child, how much my mother was juggling, right? So she was juggling being a first in many ways, juggling, being one of the only one of the only Black women physicians at her institution, and trying to advance her career in academic medicine, being a parent to a set of twins. And so often when she came home, she was she was like overwhelmed, and she needed some time to settle down before my sister and I jumped all over her and demanded, where's dinner, where are snacks. And so she would say, I need to get my bearings together. And I think what that speaks to is really like the heavy burden, the heavy load that she was carrying at that time, practicing in the 80s and 90s. And, again, I didn't recognize how much she was carrying in terms of the burden until now I am, as a parent, as a physician, as a founder of my own consulting firm, and now as an author, recognizing all that she had to carry. And that was a tremendous amount of stress on her. So she had to get her bearings together. And so that means that she had to have some time to herself to really rest and restore.
July 5th, 1997. What happened?
Yes. So just to put it in context, it was in the fall of 1996 that she was diagnosed, our mother, with acute myelogenous leukemia. We had actually, my mother was a runner. She had run several marathons in her life, and even in her 40s, she was faster than my sister and me as teenagers. We would run races together in Central Park as part of the New York Roadrunners Club. And I remember that summer of 96, she said how tired she was after one of our races, and she came in after us. That never happened. And within a few months, she was diagnosed with acute myelogenous leukemia and only given a few months to live. And unfortunately, her brother, even though he was a bone marrow match, the chemotherapy, and we were not able to, essentially she was not able to get into remission in order to get the bone marrow transplant. So those 8-9 months were very, very difficult for her, for us as a family. And she actually developed a fungal infection in her lungs as a result of being essentially immunocompromised from the chemotherapy. The chemotherapy suppressed her immune system. So she developed a diffuse pneumonia, essentially, that was due to a fungus. And she ended up passing away on July 5th, 1997. You know, that day, I thought for a long time I wouldn't be able to experience that day without feeling tremendous amount of pain and grief. Now, so many years later, it comes and it goes because I essentially think about her every day. But that was probably one of that's probably the saddest day of my sister and our lives. To lose her that day at the age of 47. So I'm 46 now. She was 46 when she was diagnosed, 47 when she died, and she was too young.
Was her leukemia, is that a hereditary disease?
So what's interesting is that the kind of leukemia that my mother developed, it was a result of something called myelodysplastic syndrome, which is actually a type of leukemia that develops usually in older people, usually older white men. So it was very rare for my mother, a young Black woman in her prime, to develop that. And in doing the research for my book and reflecting on conversations that my mother and I had, when she had gone for a second opinion for her leukemia in Boston at the Dana-Farber Institute, one of the oncologists said, looking at your chromosomes, it looks like you were exposed to radiation early on in life. And doing the research for my book, and looking at where my mother grew up, she grew up around Superfund sites where there was toxic dumping. So it's reasonable to think that my mother could have been exposed to some radiation at a very early age as a result of where she lived. We know that there are correlates with environmental racism, that in communities of color, those are more likely to have sites where there is toxic dumping and radioactive material. And so there is I think that that could have contributed to the fact that my mother developed a kind of leukemia that is very, very rare for a Black woman to develop.
Dr. Uché Blackstock, you and your twin sister Oni, who is also a doctor, grew up in Crown Heights during the crack era. What was that like?
Oh wow, that was hard, and I don't think I realized it until I got older. But we would find crack vials in our front yard. I had witnessed several people being shot on our block. But my parents, they still kept us as protected as possible. They were, I'm probably a little bit overprotective, but even despite being overprotective, we were still witness to, the devastation of the crack epidemic in our community. One of our neighbors was someone who was, a very kind woman, but who became addicted to crack cocaine. And we saw what it did to her body and what it did to her mind. She became very, very thin, very agitated, having a lot of arguments with her partner. And so we could hear that actually through the walls of our home, which were adjacent to her home. And I didn't really understand at the time, like, why was this happening in my neighborhood? I also didn't understand, like, why didn't we have a supermarket that had, an abundance of fresh fruits and vegetables in our neighborhood? Why did my parents feel comfortable sending us to the schools in our neighborhood? They were concerned about the quality of education. Why wasn't there a park near where we live? So there were so many things that I was seeing in the 80s and 90s that only as an adult was I then able to connect the dots to understand why that was happening in my neighborhood, that there was not something inherently wrong with the people who lived in my neighborhood, but it was a result of practices and policies.
Tell us about Earl.
Oh, so yeah, Earl is my father, Earl Blackstock, and he came from Jamaica at the young age of 17 to the United States. His mother had come many years before him, and he was raised by a great aunt. So my father is an immigrant from Jamaica, and when he came to New York City, he was a young man. He worked lots of odd jobs until he ended up going to college later in life. He ended up going to Brooklyn College in his late 20s, and that's where he met our mother. But my father, as an immigrant, there were certain things that were very, very important to him. One was that academics were incredibly important, and that was going to be a focus. But also owning our own home. And so my father was the one who really pushed for our family and my mom to purchase our beautiful home in the Crown Heights section of Brooklyn in 1977, a few months before my sister and I were born, because in his view, how to be successful was home ownership. And he spent many, many years fixing up our dilapidated home, turning it into the beautiful place that it is today.
Dr. Blackstock, though you talk about internalized shame, you're the daughter of a physician and a successful father, and you would have a white friend not drop you off at home, but blocks from the house.
I know. I know. And when I wrote about that in the book, it was something that I had actually thought about a lot since I was, a freshman in high school. It happened when I was a freshman in high school. But it was because, as I mentioned, there were these observations I was making about my neighborhood about, why were there so many abandoned buildings? Why were there so many shootings? Why did it seem like our neighborhood looked so different and felt so different, even though it was a community and we took care of each other, than adjacent neighborhoods in Brooklyn, like Park Slope? I always said to myself, oh, I wish we could have lived in Park Slope, which is, mostly white, more affluent area. And so I think that there is, up to a certain point, yes, my parents definitely instilled in us, pride of who we are as even as young Black children. We had to write essays about what it means to be young, gifted, and Black, and they also had us read about well-known and lesser-known Black Americans who contributed to this country. But at the same time, I think it's difficult at times not to internalize the messaging, the cultural messaging that's all around us, that there's something wrong with us. There's something wrong with Black people. And so that's why it was on that very cold winter day when I had gone over my friend's house, my white friend's house in Park Slope, and her mom had offered to drive me home. And I had her drop me off blocks from my house because I was, to some degree, ashamed of where I lived. And of course, that was like the internalized racism, internalized anti-Blackness that I was experiencing. And, looking back now as an adult on that time, that it makes me so sad that I felt that way. But sometimes I think it's something that is unavoidable, because without even knowing it, in an unconscious way, we internalize that messaging around us that we're not good enough and that there's something wrong with us.
Was that tough to write about?
Yeah, that was really tough. I mean, I definitely got emotional as I wrote that piece of the book, because it's something that I've thought about often. I actually run into that friend from time to time, still in Brooklyn with our kids. And I almost feel like if I could do it again, I would have just said, just drop me off at home, because it was a very cold day. I wasn't dressed appropriately. And I remember just like walking home feeling ashamed, walking home from after her mother dropped me off far, a few blocks away, but feeling ashamed, but also feeling a little guilty that I felt ashamed of my neighborhood and what it looked like.
Dr. Blackstock, what's the origin story of Uché and Oni, the names?
So my parents, they wanted to make sure that my sister and I had names that connected us to our ancestors. As I mentioned, my father is an immigrant from Jamaica. My mother actually is a descendant of enslaved Black Americans. And so we don't really know a lot of our history. Actually, that's something that I would love to do once things quiet down with the book. I'd love to look at genealogy and really do some research into my background. But we don't exactly know a lot of who our ancestors are. I do know that just because of some testing that they are from West Africa. And that's where many of the enslaved Black Americans came from. And so My parents felt, even back in the 70s, that it was important to give both my sister and me names from Africa. And so Oni and Uche, they both are Nigerian names. Uche means wisdom or will. It's part of a longer name. The other part of the name means God, so God's wisdom and God's will, which is a lot to live up to. And Oni means like a chief or a leader of a kingdom or society. So they're very, very powerful names that I think my parents were very intentional about choosing those names for us because they put so much love, energy, and effort into raising us and really wanted us to do something positive with our lives as adults.
Why did you choose Harvard?
For college?
Yes.
Oh, it's interesting because I went to both my sister and I, we went to Stuyvesant High School, which is one of the specialized high schools here in New York City. It's considered one of the most competitive public schools to get into. And just being in that environment, the messaging that at the time I was getting was that, obviously going to Harvard, being like the number one school in the rankings and having such, an esteemed history that was the place to go. And so when we got in, there was almost no doubt. It was like, of course, we have to go to Harvard and really take advantage of all the resources and opportunities that it has to offer. So it's like you couldn't really say no to it. I think in retrospect, to be honest with you, I think probably I should have considered a historically Black college or university like Spelman or Howard. But at that time, I think that I was probably very caught up in like what does success traditionally look like? I guess it's easy for me to say that now as a graduate of Harvard College and Harvard Medical School, I'm in a privileged position to say, oh, I should have done something different. But I do think that going to Harvard College and medical school has opened doors for me in ways that if I'd gone to another school, probably would not have.
And in Legacy, you talk about the history of HBCUs and their medical schools.
Yes, yes. So what I really love about Legacy is that I use my story and my mother's story to really, shine a light on these larger systemic issues. And there is a lot of history in it. And I think the history piece was very important for me to include because I really would like to or wanted to connect the dots for a broad audience as to why in 2024 we're seeing such a low percentage of Black health professionals, why we're seeing the racial health inequities that exist today. And so one report that I write about in the book is called the Flexner Report, which was commissioned in 1910. The American Medical Association, which is the oldest and largest association of physicians, and which has actually its own history of discrimination against Black physicians, they and the Carnegie Foundation commissioned an education specialist named Abraham Flexner to assess all 155 US and Canadian medical schools and to hold them against the criteria of Western European medical schools and in the US, Johns Hopkins Medical School. But what that report did was that it was comparing HBCUs. At the time, there were 7 in existence, which had trained about 1,500 students. But it compared them, and mind you, HBCUs did not have the resources or the same endowment, but compared them against predominantly white institutions in terms of admissions criteria, in terms of the percentage of physician scientists on faculty, in terms of what the laboratory facilities looked like. And so it led to the closing of not just some historically Black colleges and universities, but also some predominantly white medical schools as well. But what happened was it led to the closing of 5 out of 7 of those medical schools, leaving behind Howard and Meharry. And it's estimated if those 5 medical schools had remained open, they would have trained between 25,000 and 35,000 Black physicians. And when I heard that number, that was in 2020, in an article in the Journal of the American Medical Association, ironically, I thought about all the patients that could have been cared for by those physicians. I thought about all the students and trainees that could have been mentored. And I also thought about all of just the brain potential that was lost as a result of those schools closing. And also just to say that, yes, they were comparing them against these gold standards, but what was to say that they were putting out inferior physicians? Like, you cannot compare HBCUs with the resources against predominantly white institutions. It's not fair. But, I wonder, what would have happened if those schools had stayed open?
And according to the Journal of General Internal Medicine, Black Americans make up about 13% of the U.S. population. 5.4% of all physicians in the U.S. are Black, 2.6% men, 2.8% women, and you report that is less than in 1940.
Yes, yes, exactly, and especially the percentage of Black male physicians. So that's why I thought it was important to talk about the Flexner report, because people will say, okay, why in 2024 those percentages so low? And that's one of the reasons. That's one of the reasons. And so it just shows how a policy from the early 1900s can have sort of repercussions that are still echoing today in 2024. But also, I also want to say that in terms of medical schools, a lot of them rely on MCAT scores and GPA. And we know that what is predictive of MCAT scores and GPA is often socioeconomic status. Like we know that there's actually a disproportionate percentage of medical students that belong to the highest quintile in terms of income. And we know that there is an intersection between race and socioeconomic status. And so, schools are still using these very traditional indicators of success to determine who comes in and who comes out. And when you look at, communities of color and Black communities, especially, because of the legacy of redlining, because of the legacy of housing discrimination, that actually also impacts schools, because property taxes go towards funding schools. That impacts the quality of education. So what we need to really think about is, how do we support students, or even from as early as possible in the pipeline, from preschool, from kindergarten, how do we support them all along the way in terms of exposure, mentorship, sponsorship, so that we can have a more diverse workforce in healthcare?
Dr. Blackstock, we've talked about the fact that you're a legacy at Harvard Medical School, but that title has kind of a double meaning, and I want to quote from your book. During 4 years at Harvard Medical School, I don't remember anyone ever talking about racial health inequities in medicine. There was never any conversation about the glaring discrepancy in outcomes between Black and white patients, or the nuances of how to competently care for patients of different racial and ethnic backgrounds.
Yes. No, I mean, and that was my experience. And so that's why in Legacy, I talk about this process that I went through of learning, unlearning, relearning, and recognizing the educational gaps in my education and training. And a lot of the work that I mentioned in the book, a lot of the history and social commentary, those were awakenings that I actually had in my residency training and as a practicing physician that I actually did not get in medical school. I do think that medical schools today, a number of them are working towards having a curriculum that can more adequately prepare our future physicians to care for a diverse patient population. So including the history, including even the whole idea of what we call the social determinants of health, the fact that, where you live, where you work, where you pray, where you love, that has a bigger influence on how healthy you are than the decisions you make about your own health. And so, I think that medical schools are trying to do better. But again, it really was my experience after medical school, in my residency training at a public hospital, where I started seeing in my patients, recognizing that the disease and illness I was seeing in my patients wasn't necessarily a result of choices that they were making. It was a result of the communities that they were living in, the lack of access to resources, the lack of access to healthy foods, the kind of jobs where they worked, that was what was more responsible for their health outcomes than anything else.
Now, you had an experience in medical school where you were a patient.
I did. And again, when I went through that experience at the time, I did not recognize kind of like the nuances of what I was experiencing. I was a first year medical student at Harvard. I developed very bad abdominal pain in the middle of my pharmacology class. That week, I ended up going to the ER 3 times. And during those visits, I was questioned, very personal questions, and some of them were appropriate, but it felt like I wasn't really being listened to. So I was questioned repeatedly about my sexual history and activity. I was also told that I didn't seem to be in that much pain. So I was actually sent home the first 2 times. I ended up having, it was appendicitis that was missed and delayed. And so by the time that I went to the ER the 3rd time, my appendix had ruptured. And I actually ended up having very serious complications and had to stay out of medical school for about a month. And when I reflected on that experience, I wondered, would that have happened if I wasn't a young Black woman? My twin sister, who was also in medical school with me at the time, I think on the first visit was said to me, I think you have appendicitis. But even as medical students, we didn't really feel empowered to speak up at that time. So you can imagine what, the average layperson would feel in a similar situation. So it was that experience that really taught me how the importance of just even, I know this seems so straightforward, but just how for health professionals to truly listen to patients, just listen to them and not make assumptions, not have their own internal biases cloud their clinical decision making. And that was a true learning experience for me. And when I've shared that, when people have read the book, that people have talked about similar experiences that they have had where they felt dismissed, ignored, or their concerns were minimized by health professionals. And what that actually leads to is not just, a misdiagnosis or delayed diagnosis, but complications in my case, and sometimes even death for some people.
From your book, Are You Black? I realized she couldn't see my skin color under all the layers of PPE. Yes, I'm Black, I replied, hoping she could see the smile in my eyes. I could sense the tension leaving her body. Thank you, doctor, she sighed. At least I know you'll listen to me.
Yes. Yes. That is such a powerful experience that I had in the fall of 2020 with a young woman who had come in. She had been diagnosed with a COVID a few weeks prior. I was coming in with persistent shortness of breath. And, I had some complex feelings in that moment. I had feelings, I was proud I could be the doctor that she needed in that moment. But it also saddened me that she obviously had had experiences with health professionals where she did not feel listened to. And it was the point where she needed to know who I was. I had so much PPE, personal protective equipment on at the time, and that was in the spring where there was so much that we didn't know. I was covered head to toe. And it was really important for her that whoever she saw was someone who was going to listen to her. And like I said, I was proud in that moment, but it also saddened me that obviously she had had interactions where she felt that she had not been listened to.
Part of that double meaning of legacy, could this be it? Institutional distrust and racism in medicine?
Yeah, so definitely that there's that double meaning. The first, obviously being a second generation Black woman physician, but the second is really this deeply rooted history of medical racism that still rears its ugly head today and accounts for a lot of why we are still seeing these appalling statistics like, the Black maternal mortality crisis, why we still are seeing, these statistics despite advances in innovation, research, and technology. So that is the other piece that I felt so important to talk about in this book. So not only the Flexner report, but, this issue of, even Henrietta Lacks, who was a young woman from impoverished Baltimore who presented to Johns Hopkins in the early 1900s with metastatic uterine cancer and had her cancer tissue removed from her without her consent. And it's been used by biopharma companies and Johns Hopkins It wasn't until, and they've made millions of dollars. It wasn't until recently that her family received compensation for that. But I talk about, we frame, Black communities' feelings towards healthcare institutions as medical mistrust. But the fact is that healthcare and health-related institutions have proven themselves untrustworthy and have had a history of that. And so that's why I talk about this issue of institutional untrustworthiness, that it really is about, it's up to, and it's the obligation of institutions to engender trust in the community so that people, when they are sick, feel comfortable seeking care.
Besides the HeLa cells, what about grave robbers?
Yeah, so that's the other thing. And I talk about even schools, well-known schools like my own medical school, really digging up the bodies of formerly, enslaved people and using them for experimentation or using them in learning and teaching within medical schools. So, medical schools have a history of doing this. And again, it's something that I didn't know until I was a practicing physician. And so when you think about, just what kind of the symbolism of that, the dehumanization of that process to dig up the bodies of formerly enslaved people and to use that for teaching purposes, again, I feel like what that does is it is the dehumanization of Black people as well as this idea of racial or biological essentialism, that we are somehow biologically different, that we can be experimented on, and that we've seen that time and time again over the last several centuries.
Dr. Blackstock, you spend a little bit of time in Legacy talking about diagnoses bias. What is that?
So, wait, can you give me a little bit more detail about that one?
You're talking about lungs and kidney and pain and pulse oximeter readings, things like that, which I had, some of those things I didn't even know about. So,
well, it's interesting because, so one of the examples I talk about is, kidney function, how there is a race, for a very long time, there has been a race correction factor as it relates to kidney function. It's how I was educated and trained. It's up until very, very recently when you would go into electronic medical record, you would see that, when you're looking at lab values, there was a normal lab value for Black people and one for non-Black people. And I have to say that I never gave it a second thought. And I think a lot of my colleagues never gave it a second thought. It turns out that difference in the set of normal kidney values was based on a myth that Black people had more muscle mass. And there's a correlation between muscle mass and kidney function. But what that has done is not only is there a different set of values, but that actually has led to Black Americans being delayed from being referred for kidney care, because what that race correction factor did is it made their kidney function appear normal when it actually wasn't. So they were not referred for kidney care, specialty care when they needed it, and they were not placed on kidney transplant lists when they needed to. So actually the National Kidney Registries has been going back several years recently to try to find people who were not placed on the transplant list who should have been. But there is also a race correction factor for lung function tests. Again, it's this idea, and these are based on these false notions that there are differences between people of different races. But what that does is, whether explicitly or implicitly, it sends a message to health professionals that there is something biologically different about us, when really, race is a social construct, but we know that racism through practices and policies does exert an effect on our bodies that results in worse health outcomes.
What is a pulse oximeter reading?
Yeah, so the pulse oximeter is, people may be familiar with the small gadget that we, put on the tip of your finger when you go to see a doctor, or during the last few years of the pandemic, many people it was recommended that they purchase one. Essentially, it reads your blood oxygen levels. Something that was not known to many health professionals, including myself, is that for the last 30 plus years, the FDA has known that those pulse oximeters do not accurately read oxygen levels in the blood in people with darker skin. It's because when they were first manufactured, they were only tested in people with lighter skin. So, what are the implications of that? The implications of that are that during the worst part of the pandemic, when oxygen levels were being used to determine who qualified for different COVID medications, people with darker skin did not get the medications they needed because the pulse oximetry reading was saying that their oxygen levels were normal. And so we saw through a few studies over the last few years that there were people who did not get the treatments that they needed, and some people even died because of that. So that, I think, that emphasizes really the importance of making sure that we have diverse patient populations when healthcare technology is being developed, but also it was so important for the FDA to be able to communicate these inaccuracies long time ago. The reason why is because, when as health professionals, we don't just look at one number, we look at the whole patient. So even if the patient was saying, I still feel short of breath, I still don't feel good, but their oxygen level was normal, if we had known this, we would have acted on that.
Quote from Legacy: emergency rooms have become medical safety nets where social problems come to roost.
Yes. I was very naive in medical school because when I chose emergency medicine, I chose it because I thought it was a place of equity in terms of you take care of all comers, all different backgrounds, racial, socioeconomic, immigrant status. But I didn't realize until I was in residency and a practicing physician that really kind of what we see in the emergency department is a failure of our system to adequately care for patients. So the ideal is that we have a healthcare system and a public health system that prevents people from developing disease and illness. Like, we don't want people to have diabetes. We don't want people to have high blood pressure. We want to be able to take care of them in a way that they don't get to that point. And so ultimately what we see in the emergency department is the end result of disease and illness, but we also see people who are either uninsured or underinsured and who don't have primary care physicians or professionals that care for them. They're often coming in with, advanced stage cancer or uncontrolled diabetes. That is what I saw in my residency. That is what I saw working at a public hospital when I was in academic medicine. And so what we're seeing is actually a failure of our system to adequately care for patients, especially the most vulnerable, who end up using the emergency department for essentially their primary care.
Kings County SUNY Downstate Hospital, NYU Tisch Center Hospital. Dr. Blackstock, are you practicing medicine today?
So I am still licensed to practice, but I haven't seen patients in about 2 years because I am focusing on my consulting firm, Advancing Health Equity, which I actually founded about 5 years ago this month. And it is really to do the work that I felt like I couldn't do authentically within academic medicine. We work with healthcare organizations and institutions to create diverse, inclusive workplaces. And we also work with them on their external facing work in terms of how they care for patients and communities of color.
You wrote an article when you were about to leave NYU for STAT. It was entitled, Why Black Doctors Like Me Are Leaving Faculty Positions in Academic Medical Centers. What was the gist of that article?
Yeah, I mean, that writing that piece, I have to say, when I wrote that piece, I was in tears. I was in tears because I had not even imagined that I would never continue my career in academic medicine. But what happened was that, I was in academic medicine for 10 years. I was in the middle of New York City in one of the most prestigious medical schools. And even despite being in the middle of the most diverse cities in the country, I was either one of the only Black faculty or one of 2 Black faculty. So there wasn't an awareness of the lack of diversity, not only in my department, but within the institution. But later on in my tenure there, I actually was appointed to a DEI role, a diversity, equity, inclusion role in the Office of Diversity Affairs. And in that role, I was so excited to be in it, but it ended up being a figurehead role. and I really was not able to do the work that I wanted to do authentically. And I was also silenced in that role. I couldn't speak up. I began to get very afraid of being retaliated against. But all that is really in the context of, being one of the only Black faculty. I did not get a lot of mentorship. I didn't have, usually people mentor people who look like them, unfortunately. That's the informal way. And mentorship really determines how successful you are in your career. I didn't get the mentorship that I needed. I didn't get the sponsorship that I needed. I felt largely unsupported and actually undervalued and underappreciated. And at that moment, towards the end of my tenure there, it felt like I was the only one going through that. I felt very isolated. But when I wrote this piece in Stat, so many people reached out to me, not just in healthcare, but in other industries, saying, I have felt the same way. And it was incredibly validating. And I say writing that piece actually freed me because I was able to speak publicly about these experiences that I had. And to receive the response that I did was incredibly affirming.
Greg Murphy is a congressman from North Carolina, Republican, and a urologist. And recently in the Wall Street Journal, he had an op-ed, Ban DEI Quackery in Medical Schools. One quote from it: accrediting institutions are pushing all of America's 158 accredited medical schools to train future physicians in political activism, wasting precious time and resources that could be spent on rigorous coursework in preparation for medical practice. The result will likely be future physicians less qualified to meet patient needs. What's your response to that?
Yeah, and I just saw today he put forth a bill, a bill to get rid of DI in medicine. My response to that is I am absolutely appalled because, when we look at the statistics, I say, like, for example, myself as a Black woman with a Harvard degree from undergrad and medical school, I still am 5 times more likely to die of pregnancy-related complications than my white counterparts. And so I would say, why would that happen, right? Why is that happening in 2024? Because our healthcare system, our health professionals are still not adequately trained to care for a diverse patient population. Our patients are dying, and I feel like this is politicizing a crisis that doesn't need to be politicized, that we have the statistics and numbers that show that we could be caring for our patients, especially our Black patients, in a more competent way. And that, like I said, is a matter of life and death. So I couldn't disagree with him more. I feel like I'm very much aware of this movement, not just within healthcare, but outside of healthcare, to sunset DEI programs, but we couldn't be doing it at a worse time. Like I said, the statistics are only getting worse. And I will say that this also, when we look at life expectancy for all Americans, it has gone down. It's been going down since before the pandemic, and it continues to go down. And for all Americans, especially for Americans of color, I will say overall that all Americans, we're not doing well health-wise compared to other high-income countries. And that is because of income inequality, it is because of racism. And so I could not, so that's why, these efforts, these anti-DEI efforts are really very, very scary to me, because it seems like there's a very big disconnect in terms of people understanding where we are today, why are we seeing these appalling statistics, and what do we need to do about them?
And you write, health outcomes have gotten worse. Black men have the shortest life expectancy. Black babies have the highest infant mortality rate. Dr. Blackstock, what is ONI doing these days?
So ONI also has her own consulting firm. So we both are sort of doing the work that we always wanted to do within institutions, but doing it from the outside. So she also works with healthcare organizations, nonprofits, around health equity and racial equity, doing trainings, doing organizational assessments, leadership coaching. So I think, we are both trying to do our own piece to address the racial health inequities that we see today and that are worsening in our own way. So, I feel like it's a very frustrating moment that we're in, but we're trying to do our piece to make things better.
Do you see yourself going back to seeing patients?
Oh, it's interesting. While I do miss seeing patients, and I felt very privileged to have that level of interaction with people, to be there at their most vulnerable moments. Patients tell their physicians things they don't tell anyone else, even their family members. I feel like the work that I'm doing now and with my organization, Advancing Health Equity, with even writing this book and bringing these issues to a broader audience, and even to policymakers, which ultimately that's how we will make people healthier is through changes in policies. I feel like I have a bigger impact doing that than the clinical work.
You close your book with a letter to different groups, to medical schools, and to white physicians and healthcare professionals, and this is what you write. Your Black colleagues are exhausted. Your Black patients are dying. The first step toward fixing racial health inequities is for you to acknowledge that systemic racism exists. You must recognize your own biases and racism, no matter how altruistic or well-intentioned you think you are. You may think that you are treating all your patients the same, that you are colorblind, that you are giving everyone the best possible care, but you may be reinforcing systemic inequalities in your interactions with Black patients by ignoring how interpersonal and systemic racism impact their health.
Yes. Yes. I feel so privileged to have that opportunity to write this book and to be very, very clear about the messages that I'm trying to deliver. And that call to action at the end was incredibly important to me, because these are conversations, to be honest with you, these are candid conversations that we don't have in person, we don't have within our institutions. And it's very, very clear to me that if we are going to address racial health inequities, that we need everyone on deck. And I think that all health professionals would say they want to be the best care provider to their patients. But the fact is that that's not happening. We need people to acknowledge that, that their own internal biases sometimes influence how they make decisions about patients. And we have that in the data. So we need them to step up. We need them to help us do the work so that we can make sure that every American has the opportunity to live full, healthy lives like they deserve.
Dr. Uché Blackstock, what does the word legacy mean to you?
So the word legacy means to me is acknowledging, that the road is very difficult for Black Americans in this country, whether it's health-wise, whether it is career-wise, becoming a physician, and recognizing that, one, going to continue my mother's legacy of the work that she was doing in our communities, which is now called health equity work, which she started in the 80s and 90s along with her colleagues, so to continue to bring attention to that, but also to make the road a little bit easier for those who come behind us so that they're not experiencing the same challenges and barriers to access medicine or to receive culturally competent care. So, legacy has all of its meanings, but it really is to bring attention to the issues that we talked about during today's discussion, and to make sure, like I said, that people can live the long, healthy lives so they can celebrate birthdays and graduations in the way that they deserve to.
Part of the first mother-daughter Black American to graduate from Harvard Medical School, Dr. Uché Blackstock is the author of this book, Legacy: A Black Physician Reckons with Racism in Medicine. We appreciate you spending an hour with us here on C-SPAN.
Thank you so much.
All Q&A programs are available on our website or as a podcast on our C-SPAN Now app.